Okay, and now because of our our schedule is late, and then now I open up the next section. So today's this section we have two live demo case, but in the room two the BTK intervention is still on the table. So next we will so we first we see the room one. So could I move the monitor to the monitor to the room one? And hello, you any? No, this is the room one.
他不要 Q 了吗？好，等一下哦。好，可以呼吸。来，我们看一下那个 DSA 的影像。哇 ，DSA 完全 desktop run 都没有黑呢。对 ，Subphrenic 的 Sapura 的那个 feeling 都没有。这个这个地方可能是头。
Hello, Dr. Wu. I'm Song Yu Chu.
Yeah, yes.
So you are on the screen. Please introduce yourself and your team, and also have a short introduction of this patient. Thank you.
Okay. Can you hear me? Can everybody hear me?
Yes, very well.
Oh, okay. All right. Okay. This is a 57-year-old female. He got a long history of CTEP. We just finished the right heart cath, and she is a very high-risk CTEP patient because we found that its mean peer pressure can be up to 55 millimeter mercury, and the PVR actually estimated is over 13. So 13 Wood's unit. So actually, this is a very high-risk patient, and we just do the Palmate angiography, and we find there's a total occlusive lesion. I think it's A1, right A1 lesion, and there's also some other stenotic lesion, and at the vessel you can see on the screen, which is they're very, very tortuous, and there's some sign of neovascularization. So it's a type E lesion. So actually, this is a very high-risk patient for BPA. Would potentially can have very serious complications such as hemoptysis during the procedure. So actually, our strategy today we will select some. We will take the more conservative strategy for the treatment of this patient. So maybe we can find out some treatable lesion to treat later on. So we will finish the angiography, and later we will do the selective Palmate angiography and to decide which lesion to target. And but from the lung perfusion scan, we can find actually there's a large perfusion defect at the right upper lobe, and there's several small perfusion defect in the right lower lung area. But as you can see here, actually all of lesions actually are very tortuous, and there's lots of neovascularization. So we will later we'll tell the audience which lesion we are going to target. Okay. So can you see the screen and the angiography?
Yes, we can see that. Dr.
Okay.
Wu, should did the patient have the CT or CTA study before this procedure? Because you say
actually, this patient. Sorry. Please go on.
Because in the you say in the lung perfusion scan you find the report is a very big defect in the right upper lung and also some perfusion defect in the right lower lung.
Yeah.
So should the patient before the intervention need the CTA study to evaluate the status of the lung status, especially this is a chronic pulmonary embolism patient?
I think this patient chest CT could be much better. But unfortunately, we have the information which have the gene scan data. But I think 10 plus image is still adequate for the treatment strategy decision making. So I think this is to be not a problem, especially some of the the lesion is very this chest CT decision making. So if the patient have a very possible lesion, maybe he patient, I think only on the pulmonary. So
have any comment or question from the panelist to the operator?
Dr. Wu, could you introduce the setup for your BPA? What French shift and guiding and guide shift you're using?
Okay.
What guiding do you plan to use to engage the? I suppose you want to do the non-CTO lesion first. So what guiding do you plan to use to engage the non-CTO lesion and the lower lobe?
Actually, guiding caster we can choose. We can use the multi-purpose, but for this case, actually we use the Jackin's JR4 because there's some angulation is a much which better to help us to select the lesion. So now we use the right Jackin's JR4. Okay.
Professor Wu,
okay.
I'm Zheng Jintang.
Yeah. Dr. Zheng, how are you?
What kind of guiding? What kind of the long sheets? What do you?
We choose the destination long sheets without angle and. Can you hear me? I think is that the voice is all right?
Yes.
没有声音了。
Yes, we can hear you.
Okay.
But sometimes the transmission interrupt. So maybe some words we can hear. So this is the destination sheath. What the size?
Yes.
It's a 6 French, 8 French?
It's a 65 centimeter long.
Okay, 65.
Would that be enough long to reach the main trunk, the 65?
So we have to change the because change the and the microphone. And is that better?
Yes, better.
Okay, great. 我就站这边哈，好 ，OK。Now we are pushing the JR4 guiding caster into the because the patient's RA and RV are very enlarged, so it takes some time to get into the PA. Yeah.
Okay, Dr. Wu, I think you need some time
Yes.
to engage the right pulmonary artery. Now we have a
Yeah,
two
that's right.
mini lecture in the meeting. So we first we start the mini lecture from Dr. Zheng, and then I will back to you, and then about 10 minutes later. It's okay?
Yeah. Thank
Okay.
you.
Thank you.
Yeah, thank you.
Now we welcome the Dr. Zheng. He will give in a mini lecture, talk about the treatment of the chronic pulmonary embolism. Now we welcome the Dr. Zheng.
May I have a privilege to deliver the speech in Chinese? Is okay? Yes, thank you. 对不起啊，今天那个投影片很多，我用中文来讲。好，我们今天来讲这个我的治疗的一个这个治疗的那个策略了哈。CTEP 的这个病呢叫做 chronic thrombotic pulmonary hypertension， 它这个名词包括它的疾病的 duration， 还有它 etiology， 还有它的 complication。duration 呢就是它时间至少要3个月以上。好，它的原理就是 pulmonary 的这个血栓，还有它的 pulmonary hypertension 是它的 complication。所以我们在治疗的时候，我们需要去治疗它的原理。它的原因，它的 complication， 然后但是这个是从 UCSD 的这个 study， 他们过往的经验做的这样的分类，这家医院是全世界开 CTEP 做 PEA， 就是 pulmonary endartery 最多的医院，他把 CTEP 开下来的样本分成是 Type 1到 Type 4。Type 1就是近端有毛病，然后有双 burst。Type 4就是要很远端才有疾病。但是大家可以看到，不管从 Type 1到 Type 3， 就算它是远端有毛病，其实连近端都会有问题。这就跟我们要处理的策略是有相关的哈。那在治疗上面呢，我们刚刚讲过它的 duration、它的 etiology、它的 complication。在治疗上面呢，我们就要区分成 要治疗它的病因，就是 prevent thrombus 的部分，再来就是要 release 它的 obstruction， 再来最后就是要 treat 它的 complication， 就是pulmonary hypertension 的这一块。那我们用一个案例来这个开始哈，这个是一个31岁的女性哈，从台北到高雄来看，我们在2015年是11年以前，在那个时候她使用的抗凝血剂是 rivaroxaban 这个药物，主要是因为这个病人反复的 pulmonary 的这个肺栓塞，那有一天到我们的门诊来，那我们的门诊看到心电图跟超音波都是一个 RV 有 dilatation 的情况，那我们就赶快帮他安排做个右心的导管。右心导管上面可以看到，它的心输出量是正常的，但是它 PVR 是8.66个Wood，通常要小于2，所以基本上它是一个很高的 PVR。当说它的 angiography 是这样，大家可以看到它的 lower trunk 两侧的 lower trunk， 这个是右边的，在右边的 lower trunk 几乎是不见了，它的 middle lobe 其实也不好，那这是右边，是左边也是一样，在它的左下方的这个的肺动脉其实都是有严重的阻塞，而且都是在近端，所以当时候呢，我们就把它转到台大，那时候全台湾有在开的，可能就是台大，这是他当时候取下来的标本。那台大的 team 嘛，他就把他的左边的肺拨得蛮干净，可以拨到比较远端；右边的肺呢，基本上大概拨到可能只有拨到一点点的这个 segmental 的部分就拨不下去了。那可以看到他当时候它的这个PA 里面是有血栓，所以是属于这个 UCT 的 classification 的 Type 1，送他去开刀基本上是一个正确的选择哈。但是做了 PEA 之后，病人3个月之后来看我的门诊，一看超音波就是一个 RV pressure overload，然后 peak pressure gradient，TR 的 peak pressure 很高，还是跟以前一样，大概都70-80以上。再做一次个 lung perfusion scan， 还是看到两侧的 lower lung， 还有其他middle lung 跟 upper lung 都有 perfusion 的这个低肺。不过因为病人刚开完刀，他不想要做导管，大概隔了1年之后才来做导管。大家可以看到1年之后做了 PEA 之后，这左边的血管虽然当时候拨的有往下拨，但是整个 lower lung 都不见了那之前还没有去做 PEA 以前，虽然有狭窄，但是还是有血管的纹路那那时候的命 PAP 是46，PPR 开刀之前是8.33这次开完刀是8，其实没有什么特别的进步。右边的血管就更严重了，因为它拨得不够好，所以看到这个肺中让的肺中叶跟右边的下叶的血流全部都不见了那所以呢，这个病人呢开完刀之后，他说他有进步一点。那这个是 functional class 2， 在那个时候用的药物还是使用这个 rivaroxaban 20QD那因为那时候已经可以开始使用 riociguat 这个药物了，所以我们就给他用上 riociguat 这个药物用20 TID 来治疗这个他的肺高压。那问题就是再来要怎么做治疗那怎么治疗？因为我们知道。在2016年的时候是 NOAC 在台湾刚上市不久，大家都风靡使用 NOAC。那 NOAC 是不是可以使用在这样的病人我们待会可以再做讨论那再来我们还可以帮他做什么事情？在2016年的时候，大家有想过要做 balloon 的 pulmonary 的 angioplasty 吗？可能是没有，因为在那之前在欧洲做了 study， 做 BPA 是一个很危险的术式，病人 complication 可能会很多。那在那个时候呢，我们 review 了一些文章之后，我们就觉得使用 NOAC 可能不好，尤其是在最近的这些个案里面就告诉我们，就是说，如果一个 CTEPH 的病人他有怀疑合并是 APS，一定要使用口服的抗凝血剂的话，要用比较老型的不是 NOAC那我们就把它药物就把它换成是 warfarin， 把它 keep 在 INR 在2到3中间。那现在的概念告诉我们，就是说 NOAC 可不可以用？可以。以前是不行但是要慎选病人可以用尤其是年轻人尽量不要用，因为年轻人会是 APS 的机会很大如果使用 NOAC 还是有 repeat pulmonary embolism， 麻烦把它换成是原来的这个比较老型的这个 warfarin 的药物。那再来我们要 release obstruction 的这一部分最传统的方法就是做 PEA 全名叫做 pulmonary endarterectomy那在这个 在 UCSD 的分类里面啊 ，Type 1、Type 2、Type 3是可以去开刀的 ，Type 4是不能去开刀的哈，就是开刀要把简体取下来会比较困难哦，所以通常 Type 1、Type 2、Type 3会去开刀。但是我去 UCSD 的进修经验，他们连 Type 4都在开。好，那只是说这样的开哈，为什么以前会认为这是一个很好的术式？因为病人只要能够去开刀，哦，他5年的 survival 通常有82%，哦，10年的 survival 通常有70%。相对如果病人没有去治疗的话，5年的 survival 通常在50%以下，10年的 survival 可能在30%以下。好，那所以在10年前认为呢 ，PEA 这个是一个可以 cure CTEPH 这个疾病的一个术式哈，所以鼓励病人去开刀。但是现在的经验就告诉我们，就是说 PEA 这个术式其实不是 cure， 它只是 treatment of choice， 主要是因为根据现在的所有的去做 PA 的 study 就告诉我们，就是说病人的命 PAP 大概会降到25上下。好，在很早以前的肺高压的定义是大于等于25。好，那所以以前都会说它可以 cure 这个病，但是现在的肺高压的定义命 PAP 要小于20，所以基本上这个术式是没有办法 cure 病人，但是目前为止，如果是对于近端的病灶，它是一个目前来讲可能是一个最好的治疗。好，那为什么那时候会认为是一个最好的治疗？是因为把论的这个 angioplasty 太危险。好，那再来就是我们如何 treat 它的并发症。好，并发症就是这个 Riociguat 这个药本来是做在肺动脉高压上面，那发现到呢，在 CT 的病人，它也可以增加病人的活动的能力。好，吃药之后，病人也可以减低他的 PVR 跟上升他的 cardiac output， 后来就上市了。好，所以目前标准治疗就这样，要用 anticoagulant， 要做 PEA， 要给病人吃 Riociguat 这个药物。好，但是呢，做 PEA 有没有什么风险？虽然说 PEA 目前在当时认为是一个最好的治疗，但是做完 PEA 之后，根据后来的 study 告诉我们说 ，PEA 的 texture 会改变。那这些的改变，不管从 CT 上都可以看得到，或者是当 perfusion scan 就可以看得到，我们这边就不赘述。那对于有些病人他没有办法去开刀的，或者是他开完刀之后有 PEA 的，我们怎么样去做治疗？那虽然我刚刚讲，在欧洲最早做的欧洲德国从2000年做，发现到病人肺压会下降，但是病人很容易会咳血，很容易会 pulmonary edema， 很容易会呼吸衰竭。后来这个术式就被 abandon 了。不过呢，在我的 mentor Matsubawa 的那个努力之下，他们 redefine 了这个 BPA 的这个 protocol。这 protocol 里面呢有几个重点，第一个，不要用跟过往一样很大的 balloon， 我们要去打这个用气球去撑肺动脉的血管，要做 IVUS 来确定一下血管的大小，选择适合的气球来做。然后再来呢，如果是命 PAP 大于35个毫米汞柱，原则上我们只做一侧的浪，避免 pulmonary edema 的时候病人会呼吸衰竭，需要用 ECMO。好，那如果是治疗的原则上是从右下肺叶开始治疗，然后从右到左，从下到上。好，那再来就是现在需不需要再用血管内的超音波去做 PA 呢？依照现在 Matsubawa 的经验，他们现在是不做了，就直接从小的 balloon 就开始来处理血管。所以我们再 summarize 一下。现在的 PA 可以处理大的血管，大概是 main PA 或是 interlobar 的 PA。但是如果是 segmental 或 subsegmental 的 PA， 依照台湾现在开刀的经验，可能不是相当的好。所以呢，我们心脏就是我们这些做介入的医师啊，要装进市场，把 BPA 要做好。这说是我10年前所想的一件事情。因为我们的病人转去给人家开刀之后，发现到效果没有很好。这是我一开始在做 BPA 的时候做的一些 OCT 啦。大家可以看到，其实在血管里面都是一些像乳弱的一些的小孔洞，我们就是用气球把这些血管撑大，让这些的孔洞可以融合在一起，就可以减低病人的症状。主要是要增加血管的管腔。好，那 根据日本的 study 就告诉我们，就是说，如果病人他有需要这个病，他需要做术式的话，他如果合并做 PEA 跟 BPA long term 的效果最好，由 PEA 来处理近端的病灶，由 BPA 来处理中后端的病灶，这样的效果是最好的。但是如果是做 PEA alone 或 BPA alone， 虽然没有跟刚刚的两者都做的还要好，但是呢 BPA 跟 PEA 看起来在日本的 study 里面告诉我们说，其实是差不多的。好，那如果只用药物治疗的话，应该前面可以，几年之后它就会变差，跟我们的临床经验是一样哈。所以我自己的 protocol 根据 Matsubawa 在冈山的经验哈，我们大概学习了它，然后稍微做了一点点的变化。原则上，我们西洋的 projection 就是用正 AP 加 LAO 60度，好，因为跟以前的做法会有点不一样。那我们先做左边跟右边 PA 的 angiogram， 好，那用 P-tail 来打药，好，那打药的数目字放在上面。我们先做一个 roadmap， 重点不是由这个 roadmap 来看它有没有血管有没有阻塞，我们要用 roadmap 来做更进一步的 selected 的 segmental PA 的 angiogram， 好，那一个做完的 PA， 好，这个是 right low lung， 好，那对于做介入的这来讲，什么事情最重要？要做介入，第一件事情一定要能够 engage 血管最重要，所以我们一定要先认得血管。好，这是做出来的。RPA 的话呢，它的血管大概就会长这样。那我们通常会从侧面来看，好，最内侧的通常是 ACA7， 然后是 A10、A9、AA8， 然后再往上就是肺中部的动脉。A5 跟 A4 上面才是 A1、A2、A3。那基本上我们在做的时候，因为我们知道 lung 的 physiology 里面，PA 的就是下肺叶承担大部分的气体交换，还有这些血流，所以原则上从下肺叶先做，那病人的症状的改善会越大。那这要怎么去转这管子，跟我们做灌脉一样，怎么去把管子engage 血管 engage 好，对我们来讲很重要。好，那我们就不再赘述了哈。好，那右边的 PA 也是一样，右边因为有心脏给挡住，所以在认它血管会比较 crowded。好，但是做法都一样，从侧面来认你的 PA 会比较好认哈。啊，如果只有做正 AP 的话，很容易会不够好哦。我们时间快要到了，好，那我们就很快就挑这个就好。那我自己的个人经验，我把我学到的东西分成，我觉得有个3个 S 很重要。第一个，我们要让病人要尽量安全；第二个，要尽量让术式要 simple；最后要让这个术式变得很可以立刻做转换。在安全性上面，刚刚有人就问到了，好，我们怎么去 engage 血管哈？好，第一个我们要做 BPA 前，我们尽量让病人的命 PAP 要下降。依照目前现在最有的 data 过来讲，如何让 PA 的肺压下降，就是给病人吃 Riociguat 这个药物，就是 SGC 的 stimulator 这个药物。好，根据经验呢，你先让病人的 PA 下降，再去做 BPA。好，以1年做来看，效果。是跟你先做 BPA 的效果一样，但是呢，它的做 BPA 的时候的 complication 会比较少，因为肺压比较下降了，做 BPA 所带来的会咳血、咳嗽、pulmonary edema 的机会会少。那再来，我会希望要做进导管室以前，一定要先把lung的 perfusion scan 还有 CT scan 先看好，你的 target 要在哪一边？好，通常是 lower lung， 但是我们会先看清楚。假设 lower lung 的话是 A10、AA9， 或是其他的血管，我们先想好我们要做哪里。那原则上是从右下肺开始做，做完就做左下肺。那原则上我们在 puncture 的时候，除了第一次做心导管的时候，我们会 puncture A 跟 V。第二次以后我们只 puncture vein。A 就用 NIBVP 来量血压就好了。那再来术式要简单，如何让术式简单？就是要让转管子更简单，所以你需要一个 long sheath 来做 support。通常用65公分的 destination 或80公分的 shuttle。那 sedation 的管子通常刚刚有讲，我们会用 multiple purpose 的管子来做 PA 的 gauge 们 JR 哈 JR 我自己不是很喜欢用，因为我觉得 JR 不太好用。然后那再来就是或者是有一些比较特殊的血管，我们可能用 AL 或 SAL 0.75或1.0的。然后 engage 到血管之后要过病灶哈，要用比较轻的 wire， 好，原则上用实用或实用 blue。好，那在日本有一些比较特殊拿来做 BPA 的盖外，台湾是没有哈。那如果你要用有 polymer jacket 的盖外的话，像 Field 类系列的，千万要小心，有可能又会滑出去哈，所以你要抓好。好，那假设 CTO 的病灶过不去，可不可以用 CTO 的盖外？可以，大部分都是用 XTA， 好，那就不需要用到更硬的盖外哈。那原则上第一次做，第二次做啊，先从小的把论从 2.0、2.5， 顶多到 3.0 就把血管打开来就好，不需要打太大的压力。好，除了你做了第3、第4次以后，我们把大部分的血管都开过了，我们才用更大号的气球来做处理。那我目前对于 segmental 的这个 OOOFS 的位置，我通常会用 NC 把论 5.0 或 6.0 的 corneal 把论来把它做处理。好，那概念的 catheter 的选择，原则上刚刚讲过了，哦，就是原则上都用 MP 的管子就可以。好，但是有些的地方你可能需要用 JL 或是用 AL1 等等之类的。好，那再来就是我们要让这个术式要能够轻便快速，主要是因为这病人通常要来医院做6到8次的这个血管的处理，所以我们会尽量让每一次 keep 在2个小时以下 ，fluoroscopy time 要在1个小时以内，然后要把 fluoroscopy 要那个剂量要改成是最低的 contrast medium， 我们尽量小于100 cc。我们再回到我们这个病人哈，就开完刀之后，我们后来劝了1年，还是进来做个心导做个 PAG。其实你看这个 A5 跟 A6啊，其实我们是很难去处理它，但是我们后来还是把 wire 过了，好，然后把那个血管做了处理。好，大家就看一下，大概是看一下。那但是其他的血管啊，我们大概就没办法，因为我们想要去处理这个右中肺叶跟右下肺叶的血管的时候啊，因为我们连它的 orifice 在哪里都不知道，哦，因为可能开完刀之后整个都是 fibroid tissue 就封住了，哦，所以我们后来就在这地方造成一个很严重的dissection， 不过病人是没事，哦，后来还是就出院了，哦，那这些我们就大致上看一看。我在过去这几年来哈，只有前3个病人被诊断CTEPH 之后转去台大开刀，后来就不转了，哦，就自己做，哦，从2016开始做，2018再去进修，就是总共做了20几个病人哈，然后其实命 PAP 都会从大概原来的大概在40上下会降到30左右，好，其实肺压的进步是一部分，但病人他的心输出量进步更大，而且很多病人就可以回到正常的生活，甚至有一个病人哈，她是一个50岁的女生，她可以去国外参加那个重训的比赛哈。好，那我们的 summary 就是说CTEPH 基本上是一个肺栓塞一个罕见的并发症，虽然说罕见，但是通常在你肺动脉肺栓塞的病人可能还是会有0.2% 到3% 左右，还是要注意。好，那长期来讲需要吃口服的抗凝血剂，要用哪类的口服抗凝血剂？看病人哦，年轻人建议用这warfarin 哈，如果是老人家，你用 NOAC 基本上可能还可以。好，那 PEA 基本上还是一个首选的选择，但是我这几年来，我觉得CTEPH 的状况就跟我们之前做导管一样 ，Layman 以前是 CVS 的领域哈，我认为以 BPA 在亚洲来讲，几乎会取代PEA 哈，那原则上呢，除了这个之外，除了用治疗之外，药物也是很重要的，可以先给病人吃 Resicua 这个药物来降低肺压。好，大概我的报告就到这里，谢谢。
Is there any question from the audience and the panelists to Dr. Chen? Okay, I have a short question. I am a radiologist. How about the CT rules in the CTEPH before the intervention? The CT, the 电脑断层。
Okay. I will review the CT scan very carefully. Oh, sorry. I always told the radiologist I need very delicate the CT scan. So the slice should be less than no 0.5 millimeter per slice.
Okay.
Okay, so I can see what kind and so I can see where is the where the lesion where is the lesion and how can I treat it. So I always choose the balloon size before enter the cast room. Yeah.
Okay, and for example, if the CT already show the, for example, the
Yeah.
right upper lung pulmonary artery is total occlude.
Yeah.
You can see any contrast passing into this artery. It's just like the chronic CT, the CTO lesion. So will you try to recanalization?
Yes.
This?
However, the CTO the CTO lesion in CTEPH always should be treated. I think we should treat the lesion which is not a CTO. Also, we lower the pulmonary artery pressure. Then we try to treat the CTO. So yeah.
Thank you very much. Can I ask you two things? Number one,
Yeah.
what is your rationale for treating the left side before the right side? You're mentioning left before right, and then superior portions before the inferior portions.
Yeah.
And the other thing is with BPA, what is your recoil from your experience? What is the recoil rates of those vessels?
The recoil rate is very low. According to the study, the recoil rate is less than 1%. By the way, because the right lower because always because in the patient with a CTEPH, the right lower lung always be affected. So I treat the right lower lung. And the lower lung contain the most blood. So we treat the right lower lung, the patient will get improved very much. Then we treat the right lower lung, then the lower lung, then the upper lung. Okay.
Any special balloons that you use, or you just use a normal semi-compliant balloon, or high pressure?
No. For the first time, I usually use the 2O balloon, the semi-compressed balloon, not the no non-compressed balloon. Yeah.
We thank Dr. Chen and we move back to the room 1. Okay, now
Hello?
we'll
Hello?
move back to the room 1.
Because
So we switch the.
sorry, the OR is not ready because they just finished the case. So maybe let's say we can have a photo first. Yeah. So maybe we can have time to hold your glass, and then we can have a photo here, and let the Catherine to have time to prepare the next patient. Okay, so maybe we can here, and anyone audience can come to join us for the picture. Okay.
有，我觉得 venous return 有变大。我本来是在想说，这个我们在这个 bifurcation，就是这个黑白交界这个地方要再撑一枪，可能要那边应该刚刚有撑过了，然后。我现在不太敢用太大本论，因为这 pressure 太高了。
Dr. Wu, you are on screen.
Yes.
Please introduce
Okay.
your now the status.
Now we are already advanced the JR4 guiding to the right lower PA, so which is A9 branch. And initially, we cannot very clearly see the venous return. And now we target the A9 lesion with the 2 millimeter balloon and low pressure initially. And I think the effect is still acceptable because after the balloon dilatation, we can now see the venous return from the A9 area. So I think we will still going to continue to find some other treatable lesion. But I still have to mention again, because this patient is a very, very high-risk patient. So we can just maybe for the time being, we can just use the small-size balloon to prevent the complication. Because after the balloon dilatation, the patient start to cough. So I think because of this kind of type E lesion is very possible to complicate with the hemoptysis after the balloon dilatation. So we always have to ask the patient whether he's going to cough or have a sputum or not. I think this is very important. We have to be very, very careful to avoid the complication. Okay. And now we are going to search for other treatable lesion because I think the in addition to the A9 zone, the A10. No, not A10. It's A8 or A7. There's still some perfusion-free zone. So we are going to search some more treatable lesion for the patient. So according to Dr. Zheng's mini lecture, we are also following the rule. We are targeting the right lower lung first. Because it's the most beneficial zone to be targeted. Because if the venous return, we can get a good venous return, I think there should have some good effect for the pulmonary arterial pressure. Because currently the pressure is still very high. So maybe for the first 1 or 2 sections, our main goal is to lower down the mean peak pressure a little bit. And then we can target more lesion in the future. Okay.
Can we review the angio
Yeah, sure.
the process of the angioplasty? What kind of balloon? What kind of balloon did you select?
We use the non-compliant balloon. 2 millimeter, 2.0 balloon.
Okay.
Yes, and 2 centimeter long, and我们说是 semi-compliant balloon, semi-compliant balloon. Yes. Okay.
Is the pressure?
我们先 review 一下，我们放一下。
What is the pressure now? The pulmonary artery. The pulmonary artery
pressure right now, because our catheter is in the distal pulmonary artery, so it's not very accurate. Yes. So currently the pressure shown on the screen is 31, but before our procedure, the peer pressure is 55 to 56.
Because there's the pressure, the there is the pressure difference between the proximal part and the distal part. So did you dilate the proximal part with the small balloon? Because I think we always forgot to dilate the proximal part.
I think the proximal part we have reviewed the angiography. There's no big lesion around the proximal PA part. I think the lower PA pressure right now is probably because we have the catheter and the balloon in the catheter. So I think it's not very accurate. So maybe after we withdraw the guide wire and balloon, we can measure the pressure again.
Yes.
Okay, so we're now going to target some more lesion around this area. So we will search the pulmonary artery, the treatable lesion, just I think branch by branch. So now we are in A9. Maybe we will target A8 and
Dr. Wu,
and
Dr. Wu, what would be the end point of your procedure this time? Would you do until the patient cough up blood, or would you do as many branches as possible?
Okay, but if the hemoptysis is minor, we will still go on the procedure. The procedure will be go on. But if the hemoptysis is massive and the O2 saturation drop, maybe we will terminate the procedure. But and the endpoint, I think, for this patient, I think the venous return would be a very good signal. Otherwise, because before the procedure, there's just very little venous return in the distal rung. So actually, we will observe whether there's the recovery of the venous return after the procedure and the balloon dilatation.
Dr. Wu, if the patient have hemoptysis now, if it is very severe, how do you treat? Just stop the procedure, send the patient to the ICU, or we can inject some gel form to start the bleeding, or some kind of air, or some kind of.
Yeah, I think in the literature, of course, there's several reports using the cell form or blood clot to stop the bleeding. But according to my experience so far, we don't encounter such kind of serious complications so far. No, not yet. So mostly we just achieve the hemoptysis, stop the hemoptysis by just a short, just a long duration of the balloon inflation at the stem branch, and the result is always quite good.
And I think it also depends on the etiology of the hemoptysis.
Yeah.
A lot of the time is the wire injury.
That's true.
Yeah, so if it's a wire injury, then most of the time it can be treated conservatively. But if you're balloon perforation, I mean, it's a small vessel. If you use too large a balloon, then probably you will need balloon tamponade and even cover stent to seal off the lesion.
Yeah, sure. Yeah, sure. Yeah. So actually, for this kind of high-risk patient, we have to be very careful. So I always ask whether the patient feel like coughing, or whether you will test some bitter test in the mouth, because the contrast medium test very bitter. So if they got vascular injury, some of the contrast will get into the small bronchial trees. So I think and the patient cough, it will test some. The test of the contrast medium. So in that case, I think we have to, maybe we'd better stop the procedure.
And what wire are you using? The workhorse wire or some specialty
Oh,
wire?
because it's a very high risk patient, we use the run through floppy wire to prevent the perforation and the vascular injury. Okay. Oh.
Now we are on A10 or A9.
Yes.
So it's
I
A10.
think this is it's A10. Yes.
Okay. A10 is going to back. So I think it's A10. Yeah. Yeah.
Yeah, it's going to the posterior direction. Yes, that's very A10. Yeah.
The wire is not easy to get into A10. So
I think it's we already in the A10. We just dilate the A10 proximal part, and there's some hesitancy in the vessel. So I suppose that there's a web lesion around the patient cough again, and we have to be very careful. Okay. Okay, it looks a little bit better. Yeah, and there's a venous return as well. So yeah.
Sometimes we let the patient have deep breath and hold the breath, so we can see the track very well.
Yeah, we can do that. Sometimes if the patient can do the deep breath, sometimes it's also helpful to help the guide wire get into the lesion. Yeah, that's a good maneuver as well. Yeah.
If the guide wire is not easily
Now we
go
are going
into
to
the membrane, sometimes I will inflate a balloon to anchor and let the wire go into the membrane.
Yeah, that's right. Yeah, the anchor technique is also helpful. Yeah, but right now we already get into it. Okay. Okay, we'll inflate the proximal A10 with a higher pressure. Okay, test again.有出来了。OK， 好。好。
That's probably good enough for the proximal part because the distal is seems to be too small to take the 2O balloon.
Yeah, that's right. Yeah. Because there's a large area of the perfusion defect in the upper lung. I'm not sure whether we got time. contrast 打多少了？目前？用到多少 contrast？ 那我们那个 upper lung 上去看一下。
Dr. Wu.
好啊，好。
Yes. So did you inject the pure the contrast or
no.
half saline and half contrast?
We dilate one by one.
Okay.
Yeah, of normal saline. Yeah. Because if we use the pure contrast, sometimes we'll use lots of contrast medium.
Yeah, and sometimes called
Maybe just after a few sections,
Yes.
few sections of balloon dilatation.
Yes.
So we just dilute the contrast one by one. OK， 对对对，看起来应该好，看一下好了。Now we are playing the angiography before and after the balloon angioplasty, and 看一下它的那个 difference， 在前面一个。这里。Yeah, this is before. Okay, and then after, 那个你，然后最后 ，OK， 你有没有那个？哦，对，this is after. So we can clearly see the venous return getting better after the procedure. So I think maybe we just leave it for now for this zone of lesions. Okay.
Okay, Dr. Wu, 我是吴典玉，想问一下，就是 is there any chance of the floor limb dissection happen, or if sometimes we need stent or not, or if no referral phenomenon will happen in such a case?
Right. Yeah, that's a good question. Because the lesion of the pulmonary artery, especially CTEPH, the lesion-wise actually is totally different from the atherosclerotic lesion. The CTEPH lesion actually is organized blood clot. So there's no smooth muscle cell in the lesion. Unlike the atherosclerosis, there are abundant smooth muscle cell in the lesion. So after the balloon dilatation, the CTEPH lesion is, I think it's always, I think it's usually a stent is not necessary because the restenosis actually is very, very rare. It's a very, very different from the atherosclerotic lesion. But if after the balloon dilatation in CTEPH lesion, if you can see the recoil of the lesion after the dilatation, sometimes you have to suspect whether this is a pulmonary artery stenosis or not. If this is the pulmonary artery stenotic lesion, that means that there's some smooth muscle cell component in the lesion. So in that kind of lesion, we would need the stent to prevent the restenosis. But the large majority of the CTEPH lesion, we don't need stent because the recoil or the restenosis is very unlikely to happen.
If we need stent, what stent will you choose in such cases? What kind of stent?
Actually, we just use the coronary stent. It depends on the lesion, whether it's in the proximal lesion or the distal lesion. In the distal lesion, we just use the coronary stent. And if the PA more proximal lesion, sometimes the peripheral the stent will be needed.
And may I add that the data of coronary stenting in pulmonary artery is very limited. So unless there is some really severe recoil, otherwise you will refrain from stenting. Chiefly because the distal outflow usually is not very good because of the pulmonary artery hypertension. So there's a lot of vasoconstriction. So the risk of stents thrombosis theoretically is a lot higher than in arterial system. So, and most of the
Right,
time, that's
right, that's right.
restenosis or recoil usually happen in the more proximal branch instead of this distal branch. So, yeah, so maybe peripheral stent in the main branch sometimes is needed, but not in the distal.
Yeah.
Because the
Yeah,
support
I
of the
think this.
guiding sorry. Because the
Sorry, I just want to show you that this lesion, this area, actually the perfusion already good enough, so we don't target this one. This is A9, right? A 就是 A 几那个啊，这个是 8， 哎呀，是 8。对，比较外侧，对，7、8、9、8、9，对。
Yeah.
Okay. So maybe we will target upper lung whether we can see some treatable lesion or not, and then we can finish this case for now. There's a total chronic CTO lesion in the right A1. It's a blunt-ended total occlusion. Actually, this is a very, very high-risk lesion to target. So for this patient, the mean peer pressure can be up to 55. We will just leave it. Maybe after treat other lesions, if the mean peer pressure can go down, then in the next or next few sections, we can try target this CTO lesion. The CTO lesion, normally we will use a very, very hard guide wire. Sometimes we will use the Astato 40. So it's a very high risk wire. So we have to, when we try to target this lesion, we have to be very, very careful.
Should we advance the long sheath into the right pulmonary artery, not in the main pulmonary? Artery for better support.
We can advance the because this long sheath right now is not. We have to use a longer long sheath.
It's a 65 long sheath.
Be able to. Yeah, because the prolapse, this long sheath, when we, it will protruding to right the left PA. So this is there's a problem. So maybe the next time when we try to engage the destination into the right PA, we have to use the angulated long sheath. Yeah. Otherwise, you can see here when we push the long sheath forward, that will prolapse into the left PA. So table 可以高一点，对。这里好像那边有一些web。See? Oh yeah, you can see on the pulmonary angiography. There's a lot of thrombus in the. This is A6.
A6.
Yeah. « 或许可以撑一下，看一看，可能要大，对。对对对，就是让它过去。Yeah, now we will target the A6, and there's lots of thrombus and wet light lesion in the A6, so maybe it's worth targeting.
for advancing the long sheaths into the right pulmonary artery, sometimes it's very difficult. So sometimes I will use the very stiff guide wire in the guiding catheter, such as Boston Scientific super stiff guide wire. It's very stiff.
Okay.
So to facilitate long sheaths from the main pulmonary artery into the right pulmonary artery for getting more support for the procedure.
Yeah, I agree. Yeah, I think if the use a more stiffer guide wire is a help to advance the long sheath. But for this case, I still worry about using too hard guide wire because the very, very high pressure. So OK， 已经过去了，可以了。这个是2.0的嘛？可能不够。好 ，OK， 好。Later, maybe we will change to larger balloon because the size 2.0 for this A6 lesion is not enough.
Okay, Dr. Wu, please going on. We have another mini lecture, so we will move to mini lecture. Next lecture, mini lecture is from the Xinguang Hospital. Dr. Huang Yuhan. He will tell us pain control of osteoarthritis with TAMI. There's a transartery microembolization for pain control. Welcome, Dr. Huang.
Good afternoon, everyone. I am Yuhan Huang from Xinguang Hospital. I am a pain physician and radiologist, interventional radiologist. It's my honor to be here in third TVT and present the pain control of osteoarthritis with TAM, transarterial microembolization in elderly cardiovascular disease patients. To show the maximal precision and clarity for the complex technique content. So I will present main discussion in Chinese, but all the key figures and topic I will present in English. Because I have presented in Hong Kong and Japan, I think this topic is so new, so I want to present more the precision and more clarity. So this topic is focused on knee transarterial microembolization, and more important is cardiovascular disease, because we know the cardiovascular disease patients, it may over comorbidity is the PLD or vascular narrowing in the lower limb vessel. So I will focus on these CVD patients because it's my boss need me to talk. 然后大家可以放心，因为病人都是吴典玉副理事长转给我的，所以一定都是 CVD 的病人。所以这个是绝对没问题的。然后I will present 2 cases, and I will do the CTA for lower limb and show the lower limb vessel, and I will show the paper review. This is a 72-year-old female. She had left anterior and medial knee pain after further unit compartment knee arthropathy. He also have hypertension and DM. Not DM, but hypertension. But he is refractory to standard treatment, NSAID, IA, HA, Proro, and physical therapy. Diagnosis is refractory left knee pain post unit compartment knee arthropathy. 那因为这个是吴典玉主任转给我的，然后这个病人我们就有做个很完整的 survey 哈。Before the 10, we do the MRI for predict the neofacial stain. We can see the infrapatellar fossa increase T2 intensity. 然后这个通常在我们的 实务经验上，我们会知道这是一个 neofacial stent 的一个 formation, because he has unique compartment knee arthropathy. So we also do a CT for predict. 我们可以看到它在increased 一些就是它有增加一些血流吼，还有一些不正常的情况在它 medial 的 knee 的 joint 的部分。We do the CTA for lower limb. We can see the ATA, right side ATA is okay, but the PTA and the peroneal artery we cannot see because it can more calcification or luminal narrowing. In the left side, the ATA is really relatively small and narrowing. In the reconstruction image, we also can see it. Maybe it is a potential risk of PLOD patients. 所以我们在做这个治疗前，我们就是会先会先请那个助手说，那等一下随时call一下主任哦，那是不是可以取栓？没有啦，其实就是前面的话，后来我们用一个 protocol， 就是只要是有 CVD 的病人，我都会先给他做一些下肢的一些 facial 的一些 sonogram， 因为这个病人他在门诊的时候，他的 dorsal pedis 的那个 pass 其实 OK 的，可是当我们做这个CTA 的时候，我们发现其实还是有一些状况的。那在这个情况下，我们到底可不可以去做这个 TAM 呢？其实还是有一些小的一些技巧的。In the pre-tamed angiogram for the superficial femoral artery, we can see the popliteal and the superficial artery is very well, no luminal narrowing or break. 这个我觉得是最重要的关键。如果像我们前面的一些讲者讲的，如果他的大条的 vessel 都有一些 plaque， 那基本上在一些 manipulation 过程中，就有可能把这些 plaque 直接带到末端。所以我觉得应该是相对来说，它的血管要是好的，但是它末端PTA、ATA 这些没那么好，那相对来说是还是可以解决的。为什么会这么说呢？When we put the catheters, guiding catheter in the lateral inferior auricular artery and put the microcatheter in this end, we can see the moya and the neofacial stent. And the patient say that this is the pain side， 这是他疼痛的地方，跟我们的血管摄影师相符合，我们会做一个 mark 在前面。当我们有架这个 guiding catheter 跟这个 microcatheter， 我们就能确定，就算我们打的比较多，它有 regrade 的话，也不会到它的 main trunk。如果不会到 main trunk， 那应该就是不会有到 distal 端造成的风险。This is the moya, and we do the lateral inferior auricular artery angiogram, and we see the moya in the end and in the pain side. 这边，那我们什么时候是它的停止的点呢？通常我们在它 stasis 的时候，我们就会停了。所以 pre-tamed we can see the moya and the neofacial stent, but post-tamed we supersedative to the 8th facial, and we can see the stasis and no moya. In the post-tamed angiogram, the main trunk is okay. No furrow disease, no furrow decrease, or thrombus is no. But we can see the distal end of the small branch. The moya is decreased. 所以这个来说，其实就可以解答我们最担心的疑惑 ：PAOD 的病人或是一些 potential PAOD 或 CV 的病人，到底可不可以做逆这件事情？其实是可以做，但是我们需要很小心。就是第一个，我们要确定它的 main trunk 它是没有狭窄的，或是它没有一些 plaque。第二个，我们要确定我们都是勾在 distal 端，然后当我们 regrade 还有一个安全距离，不会让我们这些 independent 就是到我们的 main trunk 里面。那这个病人的疼痛 pain score is 8 and drop to 4 and persistent decrease to 2 at 1 month， 然后持续到1年，那效果其实不错。那后来他的脚的情况也都没有什么特别，就是比如说有一些新的一些 ischemia limb 的出现，这是没有的。然后第二个 case 是一个 63-year-old female， 她是 left anterior knee pain for months, progression during motion。然后他的 left ACL reconstructions in 109年，然后有打过 PRP， 他也是一个 hypertension 的一个病人，有 CVD 这样。然后 diagnosis 的部分呢，因为他做过很多的治疗 ，NSAID 或 IA、PRP 或 field therapy 可是他的效果都不好，所以我们就是给他 diagnosis 是一个 left ACA tail post reconstruction with refractory pain。We can see the preterm the angiogram. Its main trunk is okay. No luminal narrowing a break. So we can， 所以我们会做这个病人，我们会觉得比较放心。那这个 mark 的部分呢，就是在他疼痛的位置，疼痛的位置就是在比较前方然后这 lateral 的部分，所以我们大概心里面就知道说，管前面这些 lateral inferior、medial inferior， 然后 medial superior， 还有 medial genicular artery， 我们都会先勾。这个的话呢，其实在 Okuno paper 里面有提出我们勾到 medial genicular artery 的时候，其实勾到第四的端，它会有一些 shunt， 在这边也可以看到除了就是会有一些 irregular 的一个 facial stain 的话，它会有一些就是不正常的一些 AV shunt 出现，尤其是在这个地方所以当我们做这个 guiding catheter， 我们放到这条血管，我们会把 micro catheter 放得更深，这也是磨牙，然后这个就是后来出现不正常的一些 shunting， 然后我们会开始塞一些 imipenem， 甚至也有可能是一些 KIPSA 一些其他的一些栓塞物，减少它的 shunt 跟疼痛。它的疼痛改善指数呢，其实也是有到3分持续到1年，然后术后也都没有一些不正常的情况。那 paper 的部分呢，就是有72个病人然后他是 OA knee grade 1到3。follow 4年，它是 median clinical outcome and MR image change after transcatheter arterial microembolization as a treatment for mild to moderate radiogenic knee osteoarthritis resistant to conservative treatment， 是 Okuno 医生就是的创作这样，然后主要没有 serious 的一些 side effect， 像 osteonecrosis 或是 ischemia 的一个 complication。然后 minor 的 complication 就是有一些 subcutaneous hemorrhage， 或是有一些 transient 的 cutaneous color change。那其实逆 OA 的话，大家都知道，其实就一定是中年嘛，就是60几岁的年纪然后它这边重点就是会希望在 mild to moderate 的一个 grade， 如果是在grade 4的话，效果会没那么好。它 paper 上面指出，这是最重要的一张图。它其实就是，如果是 medial knee pain 就是 OA， 然后它是2、4，就是这个 medial 在痛的地方，我们就是第2条跟第4条，我们就是要勾。第2条就 descending genicular artery， 还有一个 medial superior genicular artery。但是基本上的话，我们都会全部勾，因为它会有一些 collateral 所以不能够确定说只有勾这2。可是如果你只勾2条，就这2条是一定要勾的。那如果你是比如说是像是后侧在痛的话呢，那我们就可能要再多勾1条，就是第6条 medial inferior genicular artery。那当然有一些 sports injury 的话，我们会根据它受伤的 ligament 或是 meniscus 的位置，我们再会分位置去勾它。最主要是这8条血管都会勾。然后它的paper 是说到6个月的时候，它还是会有一个 86.3% 到3年持续有80%。然后它的 grade 是 grade 1到2的效果会比 grade 3好。那因为这是一个比较新的治疗方式，所以我就做一个简短的一个介绍。那不知道大家有没有什么问题？这样。
Okay, thank you, Dr. Huang. I think OA, I think pain control is very important because not pain in knee, not only arthritis or sometimes tendon or others or PAD sometimes very complicated. How do you choose the patient or identify? I mean, sometimes the problem may be mixed. It may be not simple. Maybe may come mixed with OA or others. So if you only treat with 10, and how do you know? How do you treat then? Who, the strategy what we choose, okay? What we do next, okay?
首先，我觉得那个我的 boss 就是吴典玉主任转给我都是 knee OA， 他选得很好。其实就是 we can see the X-ray show the medial joint space narrowing, and he don't have any neuropathic symptom because numbness or paresthesia or he don't have ligament motion pain, I think is more we should to do sono to sure in meniscus tear or ligament tear or ACL, PCL. If it is okay, and we can do the 10 for the medial joint pain. But sports is also useful.
What's your embolization agent of choice?
Imipenem. Imipenem is a third generation the antibiotic. It is transient. It can live in the body maybe 2 days, 48 hours. So it doesn't make serious side effect.
Hey, I have a question. Since you're a radiologist, maybe you can share if any MRI findings or something like that before the procedure can help you to select the good responders versus those who don't respond. So maybe not just the KL score, but maybe the enhancement on the MRI or something like that. Does that give you some hint whether they will respond or not?
Before we do the angiogram, we will do the MRI. And the MRI, we can do it with the in contrast or within the contrast. We can, but in many PM or orthopedic, he will use the echo. When the echo see the increased vascularity and maybe indicate the inflammation, if the symptom duration longer than 3 months, we can do a 10 because it's a chronic pain. And in the Okuno's paper, he also do the MRI to predict the outcome. But in our experience, if the pain, if it is osteoarthritis, no other etiology, you do a 10, it can be 80% has a good result.
Sorry, Yuhan, I have one question. Before and after the TAMI, if we use the MRI to follow up, so for my limited knowledge, if the patient have a pain or inflammation, the T2 weight image will have increased density over there. So before and after you TAMI, did any change about the area of the signal? For example, decrease the T2 weight image hyperdensity or decrease the contrast enhancement?
In Okuno's paper, this one, he have follow-up MRI and can see the synovitis and the T2 weight image intensity is decreased and no osteonecrosis or cartilage. This is his paper. But in my opinion, I also follow the MRI if the patient is如果这个病人他比较特别，我才会 follow， 不然我不太会 follow。
Okay.
谢谢。
Okay, now we move back to the room 1, and Dr. Wu.
Yes.
Okay, please introduce the procedure and also the
now we are
status.
talking to. Okay, can you hear me? Okay.
Yes.
Now we are in the A6 because there's some hazardous web-like lesion. And now we are using the 3.0 balloon to dilate, which is a little bit bigger. And now we can see the angiography. There's still some hazardness in there. But the flow, in terms of flow, is much better, and the venous return is also getting better. So I think probably we just leave it for now. You can see we use the 2.0 balloon at the first, followed by the 3.0 balloon. Oh, okay. We will show you. This is a before. This is before. You can see there's some haziness, whiteness in the vessel. Yeah, and I will show you the after the balloon angioplasty. 要不要再照一张？对。那你要不要先把它推进去一点，让我们看照比较清楚一点？如果可以的话，不行哈，要 prolapse 了，好吧，算了。Okay, we will take the last picture, and to see whether there's a good venous return. Okay. Yeah, you can see the venous return improve a little bit, and haziness in the blood in the A6 is not that obvious. Yeah. Okay. Okay. I think probably for now we just leave the patient at just we won't target the upper lung lesion this time because there's a total chronic total occlusive blunt-ended lesion. Because the peer pressure right now is too high, I think it's too risky to target this kind of total occlusion lesion. Maybe after 1 or 2 sessions of the to treat the treatable lesion and to lower the peer pressure, then we can try to target the CTO lesion probably in the future. Yeah.
Maybe save for the next workshop then.
Okay. Yeah, probably.
Thanks, Dr. Wu. Great job. Yeah.
Yes.
Yeah. I think
yeah,
it will be
better.
Yeah.
Dr. Zheng, thank you. Yeah. Okay. And maybe we'll.
Okay, now we
可以灌到
move
另外一个没关系，因为那会到一些表皮的一些
room 2. Dr. Chu, shall we move to the room 2?
I'm Dr. Zhu. First, let me introduce our team. This is our master, Dr. Wang Bo, and our assistant, Dr. Liu. And you can see the case profile, right?
Yes, we can see that.
This last
So
patient
it's an
is a
elderly
77-year-old female with medical history of atrial septal defect and pulmonary hypertension. Stable ASD occluder placement in 2021. She also has history of congenital heart failure and atrial fibrillation. She suffered from severe bilateral knee osteoarthritis pain. However, due to high anesthesia risk, we will perform transarterial microembolization for her right knee pain today.
塞完的，对，给它放完，然后开个一口，应该都做出来，很好很好，这样就够了。你好，啊，那你要介绍 echo 了
OK. 现在换我了吗？
啊，换你了。
Okay, let me introduce our further data of this ladies, because this lady have multiple comorbidity, pulmonary hypertension, and she live in the very far away place. So he ever seeks some help from some orthopedic doctor, but the doctor refused the surgeon option. So we may try to treat his OA of both knee. Today she tell me the left knee is more painful, so we shift to treat the left knee first. And can we see the picture we just check later? We can see the echo.
Yes, we can see that. We can see the echo on the screen.
Yes, so we can see the meniscus is a bulge out to the surface and some osteophyte between the meniscus, and also some tendon was also misalignment. And also we can see the dynamic pressure, color Doppler. Can we check the video, the color Doppler? Can we play the video? Okay. So according to the color Doppler data, we can find a very abundant angiogenesis around the cavity of the joint. And also we can also see the data from the X-ray from AP and lateral view. We can find this patient was KL grade 4 OA. Because she has multiple comorbidities, so we decided to try to help her with this 10 procedure.
Can we change to the fluoro image we just finished? First one, yeah. And we do the, Dr. Chu do the angiography from the popliteal artery. And you can see the pain marker, metallic pain marker over the medial joint area. And you can see some angiogenesis over the medial side, just like we identified on the color Doppler. And the last one, the most prominent supply vessel is from descending genicular artery. So we first engage descending genicular artery. And then we found that the descending genicular artery is more proximal than other genicular arteries. So you need to check more proximal area to check the orifice of the DGA. And we engage the DGA, use the 4 French J-curve, and then we further engage, use micro catheter, 1.7 prograde lambda micro catheter. And you can see the angiogenesis over the medial aspect of the knee joint and just below the pain marker. So we give the antibiotics and to do the embolization. And the increment should be 0.5 cc, and we give total 1.5 cc now. This is doing the embolization. And then after embolization, we do the following angiogram to make sure that all the angiogenesis disappear. So this is the angiography after we do the embolization. You can see the angiogenesis over the knee joint disappear. And this time you will saw some new angiogenesis proximal to the knee joint. That is the muscular branch. Please don't do further embolization because that is not the angiogenesis within the joint, but within the muscle and some soft tissue. This is enough. Don't do more than 2 cc per genicular artery. But if you use transient emboli agent, we will need to check every vessel and do every genicular artery for more better results. Yeah. So we finish genicular artery, and then we will keep going to survey other, including inferior genicular artery, and lateral superior genicular artery, and lateral inferior genicular artery. So we will going to check other genicular artery. And Dr. Chu used by plan, that is also good because you can know that the genicular artery going forward to anterior aspect is the target you want to approach. Yeah. So we will keep doing the survey and the treatment. Okay. Okay. Keep doing.
Any question
just go
from the panelist? Dr. Chu and Dr. Wang, I'm Song Chu from the Chang'e Memorial Hospital. So the first question is how to choose the temporary embolization for temporary embolized agent, just like independent or permanent embolizer. So and the embolization strategy have any difference between these agents? For example, if I see you don't do the super selective embolization usually in this patient. So you mentioned if you use the independent, you will more selective. What's the difference?
Yes, actually in Europe, in America, they like to use the permanent emboli agent before because they cannot use antibiotics because it is off-label used. But in Asia, in Japan, and in Korea, in Taiwan, we use the transient emboli agent. But some doctors in Taiwan also use permanent emboli agent. But if you use permanent emboli agent, you should pay attention to the adverse effect after embolization. The post-embolization ischemic pain will be more prominent, and sometimes you will see skin ulcer. And you should use some like ice packing or painkiller and to relieve the post-embolization ischemic pain. And now there are more and more transient emboli agents introduced into Taiwan. Like KIPSA, they just passed the government TFDA proof, and now we can use it in Taiwan. And there are also many article discussion about different area using permanent or transient emboli agent. For knee, the result is no different. But for shoulder joint, like example, a French article used permanent emboli agent to treat shoulder, and there is skin ulcer identified and more painful. You can search the article. So maybe for different areas, like for knee, I think permanent emboli agent is both okay, and the transient emboli agent is both okay. But maybe for elbow joint, for finger joint, for OA finger, I think permanent emboli agent should be careful if you use that. I don't like use permanent emboli agent for peripheral joint, mainly peripheral joint. But for knee joint, maybe no different. Yeah, the result makes no difference.
Oh, sorry. Maybe I have a to misunderstand. So this patient, this use the temporary, just like the independent. Yeah. Okay.
Yeah, and we super selected the vessel, and we already embolized the descending genicular artery. Now we are going to super selected other genicular artery.
Dr. Wang, I'm Wu Dianyu from Xinguang. Two questions. Is there any heparin needed during the procedure? This is the first one. And I know you checked every genicular branch and treated by the pain guy, right? But is there any situation that has some moya without pain? In such cases, you still treat, or I mean, you just cure every moya or decide by the pain, or I mean the guided by the pain. You did embolization.
Yeah, I understand.
Thank you.
Yeah, for your first question, yeah, we will give some heparin within the water, but for me, I think we don't need much heparin because it is a not so difficult procedure. So we will only use very few heparin. And for the second question, yes, when you do survey all the genicular artery, If the moya vessel is prominent and the evoked pain is prominent, and you can ask patient, is there where you feel painful, you can give more emboli agent, like 1.5, even 2 cc or 2 cc. But if you engage, like for this patient, lateral superior genicular artery, and ask her, and she say there is no painful feeling, and this is not my usually, or I didn't feel painful sensation, you can only give 0.5 cc. Angiogenesis, moya is one situation you can do embolization. Second is according to the evoked pain by the patient. Yeah, you can combine both of these two situations to decide the amount of emboli agent.
Yes,
if not so painful, you can give only 0.5. If very painful, correlate to her pain, correlate to the pain marker, you can give more to make sure the angiogenesis disappear. Yeah.
The reason I ask the question, the neovascularization sometimes in the pain control opinion, it may be evil, right? But sometimes neovascularization may increase the tissue healing or something. So if you hear all moya, maybe the patient underwent the surgery before. Will it decrease the healing or something? I mean, you know. So.
Yeah, I know.
So,
but for angiogenesis can be good to be healing, and it can be also be bad to make your healing more delayed. And we also find there are micro AV shunt formation on MR angiography. Let's make vascular steal syndrome. Let's make your healing more delayed. And so our target is not for acute trauma or acute inflammation. We usually on the patient with chronic inflammation, chronic pain, more than 3 months or even more than 4 months, 5 months. The vessel angiogenesis is bad angiogenesis. For me, I will do the 10 first to stop the bad angiogenesis, and then I will combine with some regeneration injection to reboost the healing process. Because for chronic inflammation, the angiogenesis is not help you to heal. It stop you to heal by the micro AV shunt, by the Steele syndrome. Just like tumor angiogenesis, that is not a good angiogenesis. That is a bad angiogenesis. You should stop the bad angiogenesis and then reboost the good one. Very good. And then 可以跟他们讲. And then Dr. Zhu now approach the medial inferior genicular artery. So you can see can you see the fluoro image, right?
Yes, we can see much moya vessel near the marker.
Just below the marker.
Yeah, below the marker.
So I will do the embolization and ask the patient, does she feel some evoked pain?
Okay. So now we'll give some 1.5 ml.
不用那么多，0.5到1 cc。
Okay. 我们先用0.5好了。0.5 first.
0.5 first. Don't give too much one time. Yeah. Oh, you can 这样够了。
We can ask the patient.
你有没有觉得就是膝盖内侧平常痛的位置，现在有痛的感觉 ？Hello， 有吗？目前还没有，是不是？刚刚有没有？刚刚治疗的中间有没有觉得内侧痛痛的？有吗？有啦吼。好啊，我们现在药效会慢一点给你，等一下会开始觉得内侧痛痛的哦吼。如果你有感觉，你跟我讲哦吼。
我稍微拉回来一点。
可以啊。现在都还没有吗？
有没有一点点的感觉，阿姨？
那你再给一点点就好。
对，再多一点。
好，我们刚刚we do the descending genicular artery first, and she said she feel the evoked pain, but now she say there is no so prominent the evoked pain, so we give Other 0.5. If she still tell me no painful sensation, maybe we just stop here. But for DGA, she said yes, she feel evoked pain, and that is the painful area she feels. So we will give more emboli agent for her to treat. Yeah. 你现在有没有感觉痛痛的？有没有感觉？有的哈，有了哈。你平常这边是你痛的位置之一吗？对啦，对啦哈。所以他跟我们 and we do the embolization and ask her did she feel evoked pain and she say yes. And I asked her is there she usually feel painful in her usual day and she say yes. So I know this is the target vessel. So where we treatment is okay, it's good for her, yeah. Okay, we will show the angio after about embolization. Patient will tell you is this the correct vessel or not. But if she didn't feel so painful, you can still give some emboli agent, few emboli agent, because transient emboli agent is very safe. The normal vessel will make the emboli agent resolution. But the angiogenesis, because the endothelium sound different, so the malignant, the bad angiogenesis will destruction, but the normal one will be recanalization using transient emboli agent. Can we see the angio? Can we see the angio? Can we see the angio after embolization?
Yes, we can see that.
Yeah, we can see the much decrease in the neovascularization.
Should we kill the all moya, or you think just this status is adequate? I see the just below the clips have a little bit contrast stain.
Yeah, for my opinion, and that's Dr. Okuno, the maximum amount is 2 cc per vessel if you use transient emboli agent. So, and sometimes you will see some new moya-like vessel. That is because you already embolized the bad one. So some angiogenesis is from the muscular branch or from the soft tissue branch. So even you see the angiogenesis, don't do more than 2 cc per vessel. 2 cc is my maximum amount. Even I saw the angiogenesis, residual angiogenesis, I won't do further embolization. And if she say, yes, this treatment is effective, maybe you can arrange second times, yeah. You don't need to make pressure to yourself, yeah. Yeah. Okay. And Dr. Zhu are trying to engage lateral branch. Although she complained about medial knee joint pain, but sometimes the lateral one, for example, the lateral inferior genicular artery, it will go to the anterior knee joint area, the infrapatellar area. So it's just like a wave and around the knee, genicular arterial wave. So if you use transient emboli agent, Dr. Okuno and other countries' faculty suggest engage every genicular artery. It will bring better results.
Dr. Chu and Dr. Wang, you use the microcatheter is 1.7 French. Do you have any special shaping for the microcatheter or wire? I see the wire and the microcatheter have a special or more curve. Do you prepare that?
Yes, we have some shape about 2 different shape in the proximal portion. Maybe you can, because I'm a cardiologist, Dr. Wang is the radiologist, but the principle to enter the vessel is, the concept is the same. So we make some different shapes so we can feel the contour and some takeoff feel of the vessel. So it will enhance our successfully to enter some side branch.
We can make the shaping of the microcatheter. For me, I will both shaping microcatheter and the micro wire to make it like a J curve. And the guiding catheter I used is also J curve, and it will make you more easier to engage the vessel because the popliteal artery is very large, but the genicular artery is very small. So you make a curve, and it will make you more easier to engage the orifice. 没有，它可能在那个 knee joint 的那个地方，或是你也可以用那个 guiding catheter 下。有时候你用 micro 不好播，你只用 guiding catheter 下去。对对，你用 J curve 下去。And 那你记得 micro Y 要在 micro catheter， 你现在跑出来了，对吧？拉到了。对对对，你给它放深一点，你把 micro catheter 放深一点。So this is the wireless technique, and we can use the microcatheter as the wire for four French J curve, but that is because this catheter is soft. 那你可以打血液机确认有没有对到开口。And because Dr. Zhu used biplane, so on the lateral view, you should make the curve toward the anterior aspect, and use AP view to make sure the guiding catheter toward the area you want to engage. 应该还没有，还没有。
Okay, very nice job, Dr. Wang and Dr. Zhu. Okay, now the time is over more than 20 minutes, so I think we have to close this section, right? And very nice demonstration. And thank you. We can keep going on. Okay. And now we are going to closing. Okay. We welcome the Dr. Xu Bochao. Okay. Okay.
I think thanks for every moderator, commentator, and everyone come here to join our first day's meeting. We are really happy for your joinement. And today we demonstrated 8 cases in Kaohsiung Medical University Hospital, and there is also a lab demo in Singapore. And let me see. Dr. Shiven demonstrated the Rotarex device, and Dr. Soga demonstrated the Jetstream device. And Dr. Ren Guangli showed the BTK lesion using the RotaPro, and Ida Sensei showed us the BTK treatment technique. And Dr. Dianyu Wu showed us the very wonderful chronic DVT CTO penetration and standing. And Dr. Yizhe Wu showed us the BPA for the CTOP treatment. And Dr. Junyuan Zhu and Wang Bo showed us the tummy treatment. So I think we all learned a lot from today's meeting. And in the next day, we will also arrange 8 cases of PAD and VTE treatment in Kaohsiung Chang'e Memorial Hospital. And wish you can come again to give us more comment and share your precious experience. Tonight we also have a dinner night, and we hope you can come in. And thanks for everyone, and see you tonight and tomorrow. Thanks for everyone. Thank you.